Yes, you can start, sir.
Uh, Good afternoon. Myself, Dr. Rajendra Jagtap, President of Society of Emergency Medical Services Maharashtra, and one of the founder member of PMC Zone 3 Doctors Group and Disaster Medicine Forum. I welcome all the doctors for this monthly meeting and webinar. The topic of this webinar is a dengue and chikungunya PMC approach. And for this, we have an eminent speaker, Dr. Sanjeev Wavre sir. We have a chief guest, Dr. Peter Patel from Birmingham, convener Dr. Paras Doshi, and coordination with PMC and private doctors is done by uh, Dr. Deepak Pakhale sir, who is a zonal medical officer of Zone 3. मित्रांनो, योगायोग आज असा आहे की फेब्रुवारी 2020ला की ज्यावेळेस जगामध्ये कोविडची सुरुवात झाली होती, परंतु भारतामध्ये अजून पेशंट्स, केरळमध्ये काही सस्पेक्टेड पेशंट सापडले होते कोविडचे आणि पुण्यामध्ये एकही पेशंट नव्हता. त्यावेळेस डॉक्टर संजीव वावरे सर, की जे असिस्टंट मेडिकल ऑफिसर ऑफ हेल्थ आहेत पुणे म्युनिसिपल कॉर्पोरेशनचे, त्यांनी पुढाकार घेतला. आमचे लंडनवरून, बर्मिंगहॅमवरून डॉक्टर पीटर पटेल, ते त्यावेळेस पुण्यात होते, त्यांनी पुढाकार घेतला. भारतीय विद्यापीठ मेडिकल फाउंडेशन सोसायटीनी चार फेब्रुवारी 2020ला आम्ही एक ट्रेनिंग ऑफ अ ट्रेनर TOT प्रोग्राम घेतला होता. त्यावेळेस पुण्यामध्ये एकही पेशंट नव्हता आणि तो वेबिनार आम्ही घेतला होता TOT प्रोग्राम. तर तो घेतला होता कोविड-19 ची मॅनेजमेंट कशी, कोविड-19 येणार आहे, मग त्याच्या संदर्भात आपण काय काय प्रिपेअर्डनेस करावा म्हणून. आणि त्यावेळेस स्पीकर होते डॉक्टर पीटर पटेल आणि त्यावेळेस चीफ गेस्ट होते संजीव वावरे सर. हा योगायोग आज असा आहे की आज चीफ गेस्ट आहेत पीटर पटेल आणि स्पीकर आहेत संजीव वावरे सर. मला आठवतं की त्यावेळेस वावरे सरांनी, जर समजा पुण्यामध्ये कोविडची एंट्री झाली तर महानगरपालिका कशी तयार असणार आहे, काय काय केलं पाहिजे, कसं प्लॅनिंग केलं, ॲज अ प्रेझेंटेशन दिलं होतं सरांनी. खूप छान प्रेझेंटेशन दिलं होतं. त्यावेळेस आपल्याला कोविडचं काही माहीत नव्हतं, काय होणार आहे, कसं होणार आहे, काय. तो वी कॉल इट ॲज अ BC, बिफोर करोना. आणि त्यानंतर मग आपल्या सगळ्यांनाच माहिती आहे, आपण सगळ्यांनी जीवावर उदार होऊन सगळ्यांनीच, म्हणजे प्रायव्हेट डॉक्टर्स, गव्हर्नमेंटचे डॉक्टर, गव्हर्नमेंट सिस्टीम, सगळ्यांनी कोविडच्या काळामध्ये आपल्यानी जीवावर उदार होऊन सेवा केली आपण. आणि आता कोविड-19 कंट्रोलमध्ये येत आहे. तर हे जे आफ्टर करोना जे आहे, आफ्टर करोना, आता फर्स्ट वेव्ह झाली, सेकंड वेव्ह झाली, तर त्याच्यामध्ये देखील आपण आता हा परत एक वेबिनार घेतोय आणि आपल्याला परत ज्यांनी सुरुवात केली होती ट्रेनिंगची, हे प्रिपरेशनचे, तर ते डॉक्टर पीटर पटेल आणि वावरे सर इथं आलेले आहेत. तर वावरे सर आज स्पीकर म्हणून बोलणार आहेत. आपण आता कोविड करतोय, पण कोविड बरोबरच डेंग्यू आणि चिकनगुनिया हे देखील खूप महत्वाचे आहेत. बाकीचे आजारही खूप महत्वाचे, त्याच्याकडे दुर्लक्ष होणं योग्य नाहीये. म्हणून आज डॉक्टर वावरे सर इथे डेंग्यू आणि चिकनगुनिया PMC अप्रोच काय आहे त्या संदर्भात बोलणार आहेत. and after that Dr. Peter Patel will talk about his things. मी वावरे सरांना सगळेजण ओळखतोच आपण, परंतु वावरे सरांची थोडक्यात ओळख करून देतो. वावरे सर, डॉक्टर संजीव वावरे सरांनी MBBS, DPH आणि DCH केलं आणि ते आता असिस्टंट मेडिकल ऑफिसर ऑफ हेल्थ आहेत पुणे म्युनिसिपल कॉर्पोरेशनचे. तसेच हेड ऑफ द डिपार्टमेंट ऑफ एपिडेमिक डिसीज कंट्रोल सेल, वेक्टरबॉर्न डिसीज आणि पब्लिक प्रायव्हेट पार्टनरशिप प्रोजेक्ट PMCचे जे आहेत त्यांचे ते सर प्रमुख म्हणून काम बघतात. नाव आय रिक्वेस्ट डॉक्टर संजीव वावरे सर, हु इज असिस्टंट मेडिकल ऑफिसर ऑफ हेल्थ पुणे म्युनिसिपल कॉर्पोरेशन, आणि की ज्यांच्या प्रयत्नामुळेच हे पब्लिक प्रायव्हेट पार्टनरशिप झोन 3 प्रोजेक्ट जे ग्रुप चालू केले आम्ही, डिझास्टर मेडिसिन फोरम चालू केलं, तर ते डॉक्टर संजीव वावरेंच्या प्रेरणेने पीटर पटेलच्या मार्गदर्शनाखाली सुरू केलं. अजूनही ते ग्रुप चालू आहे. तर मी विनंती करतो वावरे सरांना की त्यांनी मार्गदर्शन करावं.
Hello, good afternoon everyone.
I hope I'm audible to all of you. Am I audible?
Yes, 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 yes.
Yeah. So today's topic is about chikungunya and dengue PM. Few words about the contribution of the private practitioners in epidemic of corona. Before I give lecture or before I speak anything about chikungunya and dengue, I must congratulate and I must thank all the private practitioners throughout the city, across the city, for their contribution in COVID management, treatment, contact tracing, testing, everything. They were involved in each and everything. On top of that, all the private practitioners across the city were also involved in the home isolation management of the patients. So I must congratulate all of you. I must thank all of you for your lucid contribution in the COVID management. So we'll go to our main topic today, the approach of PMC towards chikungunya and dengue. My message to you is very crystal clear, very simple. PMC just require few things from private practitioners, and one of the few things is topmost priority is active participation of all the private practitioners. Since chikungunya and dengue is a notifiable disease, so your first duty to inform, to notify the disease and to inform it to the municipal authorities, whether it is in a form of email, whether it is in a form of verbal communication, whether it is in a form of uh, letter, whatever it may be, but you must inform, you must notify the disease called dengue, whatever number of cases you are dealing with the dengue cases in day-to-day practice, whether it is in the OPD basis or in the hospital. So you are supposed to inform all the name, address, telephone number, and the condition of the patient to any PMC authority. For example, you can either inform it to the local ward office level, ward medical officer or zonal medical officer, or you can directly approach to me also. I think you have my email ID, official email ID. Again, I'll repeat it. It's a PMCKITAK, PMCKitak@gmail.com. So whatever communication regarding the dengue case, whatever communication regarding chikungunya case, you can communicate with me or communicate with our office on this email. Again, I'll repeat that email, PMCKITAK@gmail.com. So our approach is simple. I told you, we just need, you are supposed to inform. Second thing is that what are the things likely to happen if you don't report it, if you don't notify it. So what happens if you seeing the patients coming across various patients of chikungunya and dengue in your day-to-day practice, whether it is in the OPD or in hospital, but you don't report it, we are going to miss that particular pocket, and havoc can create in that particular area. Until and unless you report it, as my team from the ward office, local team will not approach there, will not do their preventive actions like finding the breeding spots, identification of breeding spots, container survey, IEC, information education communication, and spraying of the insecticides and fogging in that particular area. So both the things, preventive and curative, part of curative, not exactly curative, because curative part is with you, and I'm not going to elaborate on curative part because since eminent speakers are there sitting right in front of me, the physicians are there, DNB, MD medicine people are there, they can elaborate, they can narrate about the management of chikungunya and dengue. I'm just here to explain you what PMC expects, what PMC has approached towards the chikungunya and dengue. First and foremost thing is you report it, either you report in a form of telecommunication, WhatsApp, text, email, or letter. Whom to report, I gave you already email. If you know any sanitary inspector nearby in your area, you can call him, you can contact him, you can give the address. you can directly contact ward medical officer, you can directly contact zonal medical officer, or you can directly contact them. So mapping of the cases is most important. So where the more number of cases are coming up, we can map exactly, and preventive action and curative action can be taken in time to prevent further exposure of the more number of people, or to prevent the epidemic of that particular disease. One more thing I have observed since couple of years, dengue comes in phase manner. See, for example, in way back in 2014, there was a havoc in the Pune city for dengue because of dengue. Almost 8 to 9,000 suspected cases were there at that time, that point of time, and more than 2,000 positive cases were there, and almost 35 to 40 deaths were there occurred in year 2014. Then again, it became dormant in 2015, 2016, 2017. There was not much rise in the cases. Again, rise has seen in year 18 and 19. Again, in last year, 2020, there were very less number of cases. This year also, compared with the last 2-3 years, number of cases are definitely less. Though suspected cases are more than 2,000, but positive cases are less than 500 till today. It is also expected that in the month of October, when there is no rain as such, but there is a humidity, percentage of humidity is very favorable for the breeding of especially Aedes aegypti, those who breeds in air water. So we since last 18 days we have observed only 68 cases, positive cases, and from January till today we have only 498 positive cases. So suspected cases are more than 2,000. So I would like to narrate upon few things: what is suspected and what is confirmed case. See, as a private practitioner, you must be having with you NS1 kits and all, either in your OPD or in your lab, wherever, or in your hospital, you must be having your kits where you are doing NS1. But government that doesn't agree with NS1 positive until unless it is IgM done by ELISA method. If it is done by ELISA method, IgM is positive, then we treat this case as a positive. Until unless it is not ELISA positive, we'll treat this as a suspect case. But from PMC's point of view, whether it is suspected case or whether it is a positive case, the approach is same. My team is going to visit that suspect case also. They will conduct the container survey. They will try to find out the breeding spots. They will issue the notices if that particular defaulter have been doing same faults on repeated basis. First of all, they will give notice. If they don't listen, we'll fine them. If in spite of fining them, if they don't listen, we'll put them in a court of law. We'll have a suit against them. So this is the simple and very crystal clear approach of PMC. If you come across the case, any single case or any multiple cases at particular point of time or at particular area, you must report it to the PMC so that PMC can act upon it in time and further epidemic can be saved. So anybody is having any question in this notification or notifying the cases, communication? Dr. Jagtap.
Any questions? So might be they will ask the question on the chat box, but we will continue.
Perhaps, Dr. Maure, it might be good if you can actually spend a couple of minutes on differential diagnosis between chikungunya and dengue.
Yeah, basically I did not touch upon it because there are physicians sitting over there. I am just looking in point of view of the preventive aspects. So for if you want to go in the details of even dengue, simple dengue shock syndrome, dengue hemorrhagic fever, and chikungunya without complication and with complications of chikungunya. I think more than me, my colleagues, my fellow colleagues, physicians who are
Dr.
being
Paras
present
Doshi.
there, they
Yes,
can
yes.
elaborate more upon it.
Requesting Dr. Paras Doshi, sir, who is a convener.
Yes.
Yeah, sir.
So basically, in clinical practice, sometimes it is pretty much difficult to differentiate between dengue, chikungunya, or a simple viral fever. So basically, about dengue presentation, the patient presents with some basic symptoms like fever, body ache, myalgia, generalized weakness associated with abdominal pain, and petechial rash. So dengue can be diagnosed simply many a times with some petechial rashes. Petechial rashes basically start from the chest and then it covers all the body. So if any patient comes to our clinic, so when he explains his symptoms and if there is a fever associated with body ache, so we must definitely look for a petechial rash. So this is one of the symptoms of dengue. And then we should ask if the patient is more symptomatic and he is suffering from a severe form of dengue. Then we should ask him the color of stools, if it is black colored stools, or if he is having some bleeding from any other sides. This is about dengue. So now dengue is also called as breakbone fever. Means it is like the body ache is so severe that it is just like breaking a bone in the body. Now chikungunya on the other side. So the basically incubation period of chikungunya is up to 4 days. And after 4 days, the patient has symptoms like fever. He has past history of fever. Many a times the patient comes to your clinic saying that he had a history about 4 or 5 days back or around 1 week back. And then he comes with severe body pain. Sometimes viral rash is also there. And in dengue, there is retroorbital pain. In chikungunya, there is less chances of having retroorbital pain. So, differentiating on clinical basis, we have to keep these all things in mind. At dengue cases, petechial rash, stool occult blood, and retroorbital pain, and fever is there for last 3-4 days, then most probably it is a dengue. If there is a past history of fever and then the patient presents with body ache and multiple joint pains, then it may be a chikungunya. So we have to look minutely, and then of course the locality is also very important. We should ask about the history, where he lives, in that area which virus is common, what is the locality. That is the most important thing to ask. If any of the family members or any relatives or any of his friend is suffering from dengue or chikungunya, that history also helps in diagnosing these symptoms. So basically, depending upon these parameters, clinically we differentiate between dengue and chikungunya.
Thank you,
Dr. Paras.
Dr. Paras Doshi, sir. Yes, clinical differentiation, clinical diagnosis is also very important. With that, the management by the PMC approach is also very important because we have to manage this epidemic. So, I request Dr. Peter Patel, sir. So,
So before that, Dr. Jagtap,
I'm
just one question.
Sorry, I said Fawad Sahab hasn't finished. Let him finish his excellent presentation, please.
Doctor, I have just one common question which can be can help to all the private practitioners in their day-to-day practice. And my question goes to Dr. Paris. See, unless there are petechial hemorrhages or platelet falls down below 50,000, nobody thinks about the fresh plasma, frozen plasma, or platelet transfusion.
Yes,
But
yes.
can you diagnose it clinically? Can you predict any patient? There are group of patients. There are group of signs and symptoms to the patients. The simple signs symptoms like severe body ache, joint pains, myalgia, retroorbital pain,
Yes.
abdominal pain, and rashes, and high-grade fever. So which group of the patient with which group of the signs and which group of the symptoms can land up into the dengue hemorrhagic fever or dengue shock syndrome? Can you define such group of the patients? Such patients are likely to land up in this problem. Is it possible to help clinically to diagnose such patient can go in that kind of complications?
So this depends upon the day of presentation of the patient. If the patient presents
Okay.
lately, if on second day of illness, if a dengue patient presents, and if he takes treatment at that time, then these symptoms are less common.
Okay.
Because basically what happens in dengue, the patient, because of the illness, the patient's appetite is decreased, there is a capillary leak, there is hypotension. So these are the late presentations: dengue hemorrhagic fever, dengue shock syndrome. So these mostly happens at late presentation. And if the patient comes lately to your clinic, most of the patients, basically, they are initially treated at the basic level, then they don't land up in hemorrhagic fever or shock. So the day of presentation is very important. Second, we have to check the vital signs. Vital signs are very important in dengue patient. We have to check for respiratory rate. We have to check for pulse. We have to check for BP. So in dengue patients, there is bradycardia. There is viral bradycardia, the viral myocarditis. So whenever a patient comes to our clinic, the most important thing is to check the patient's pulse. If he is in bradycardia, then it seems that there is a viral myocarditis. Then his heart is also affected in short. Then next we have to check his respiratory rate. If the respiratory rate is tachypneic, then there is pleural effusion in that patient. So these are vital signs indicate that how severe is the patient, how severity of dengue it is. And these patients who are having bradycardia, hypotension, pleural effusion, who has tachypnea, who has severe abdominal pain with a gross splenomegaly, hepatomegaly, whose platelet counts are decreasing, WBC counts are decreasing, whose intake is less, these patients are more prone for these complicated symptoms. So basically, the day of presentation of the illness is more important in this patient. And on seeing these vital signs, we can predict that this is initially starting phase or this is a late phase, who is in shock or who is having bleeding. So depending upon this, we can decide that this patient is going to land up or these patients are having more chances of having hemorrhagic fever, hemorrhagic tendencies, and these all things. Then other thing comes that if he is on some antiplatelet agents. So we have to ask the detailed history of diabetes, hypertension, whether the patient is of ischemic heart disease, that if he is taking some tablets of ecosprin, Brilinta, Clopidogrel, that also we have to take in consideration. Next thing comes that many a times many these patients took over the counter drugs for 3-4 days. And these over-the-counter drugs are more prone to cause hemorrhagic tendencies in these patients. So they take nimesulide, diclofenac. These all drugs are more prone for hemorrhagic tendencies. I have seen many patients in clinical practice who are having more than 50,000 count, but still are having bleeding tendencies. These, so we have to take proper history of these patients. If they have taken over-the-counter drugs. If last week only one patient was there who were having 70,000 platelet count, but still there was profuse gum bleeding. It was so profuse that I have to give him some injections to stop the bleeding. Because of the bleeding, his BP was down. After asking detailed history, he had taken nimesulide for 3 days and then landed into hemorrhagic tendencies. So these all things depend. Who is going to land, we can predict from these all things. So detailed history and taking vital signs are one of the major things in dengue. Yes, sir.
Vavre sir, would you like to add something more?
No, no, it's okay. That's what I wanted to. Can you clarify or can you classify groups of the patients? Which patients can go into the dengue hemorrhagic fever or dengue shock syndrome, which is beautifully explained by Dr. Paras. Thank you, Dr. Paras.
Yes, yes. Thank you, sir.
Thank you, Dr. Paras Doshi sir. Thank you, Dr. Vavre sir. In spite of your busy schedule, we know your schedule, but you are here to guide us. So I thank specifically Dr. Deepak Pakhale sir for his good coordination with private doctors and government system. So I thank Dr. Deepak Pakhale sir, who is a zonal medical officer on Zone 3. Uh, Friends, here we have Dr. Peter Patel, sir, who is international director of disaster medicine, and he had a saving life project, and daily he give us guidelines, international guidelines. वावरे सर, आपल्याला आठवत असेल सर की आपण भारतातला सगळ्यात पहिला सर आवाज येतोय ना वावरे सर?
Jagtap sir, I'll just attend one call and I'll get back to you in 2 minutes.
Okay. So it was a first training program for the COVID-19, which was held in Bharati Vidyapith in 4th February 2020. So since then, Dr. Peter Patel is guiding us, giving international guidelines, not only for the COVID management, COVID, but various disasters occurring around the world. He is here to guide us. I request Dr. Peter Patel, sir, to guide us. Dr. Peter Patel, sir.
Okay, good afternoon, everybody, and I'm delighted to actually join you once again. Dr. Vavre and Dr. Doshi's presentations were excellent. They were very clear, and in my opinion, they have great knowledge which you can share amongst it. The important thing they mentioned is actually differentiating between chikungunya and dengue. Dengue can lead to high mortality. And one of the things which is there that if you see dengue becoming at an epidemic level, then one of the things is not only hospital beds, but to have a reserve stock of platelets. Okay, and that is sort of something which blood banks or people should be looking at. But I'm not going into more details about clinical symptoms or treatment. I'm just going to give you an overview of vector-borne diseases and then where essential information is available and how can we actually join one of the international groups on resilience building for cities against epidemics like dengue and all that. So if I can actually have, if I can share the screen, please. Can I have DigiShield share screen, please?
Piyush?
Okay, are you getting the screen now?
Yes, yes, sir.
Okay, let's. Okay, so let me just dispense with this. Okay, so the point I was trying to make is those who have attended the previous seminars, actually, this is just to say that the Faculty of Disaster Medicine for India, Nepal, and Sri Lanka is just about to join us, but we have international partners, which is National Association of Primary Care, which many of your private practitioners in Pune are private practitioners in general practice. We have Public Health England, which is equivalent to the Department of Public Health in Delhi. And then we have the Crimedim, which is Novara in Italy, which actually do European Masters in Disaster Medicine. Now, ignore the rest of the slide. The most important one is how do we join, become a member of community, making cities resilient, which is a United Nations program. And maybe this can be a small program which we can actually pilot here. So looking at epidemics and pandemics, impact on healthcare and communities. So what I'm going to talk about is a key aim is urban resilience building. So on the left-hand side, you'll see the Pune district, and of course, all the districts of Maharashtra. Population about just over 9.44 million out there. Density is quite high, 600 per square kilometer, and it's just about 6,040 square mile in size. So it's quite a huge task. So one has to, if one actually has to take Maharashtra as a whole, then that is like taking the task of actually a European country. And then if you take Pune district, again, because of population density, it is actually quite a tough job. So in terms of urban resilience building for epidemics and pandemics, it's no different to any other disasters. It's planning, preparedness, and response. And again, Dr. Wavre is an expert on this one. Important to differentiate between endemic and epidemics and pandemics. Just coming to COVID-19, it is becoming an endemic disease worldwide, including United Kingdom, Europe, United States, India, China, wherever it is. They are not going to get rid of COVID-19. It is going to remain endemic, but hopefully we'll be able to keep it at a very low level. Okay. Important to understand is condition to declare an epidemic or a pandemic. This is where Dr. Wavre's team comes in when they are monitoring things like dengue, chikungunya, COVID-19, or malaria. Then they have to decide that how many cases did we have detected in a particular period. At that point, we say we have an epidemic. Okay, so this is and then the other main key factor for everybody in healthcare and including community is to understand why do epidemics and pandemics occur. So these are just the basic principles which we should look at. As you know, chikungunya and dengue, they're vector-borne diseases. Okay. And many vector-borne diseases are preventable through protective measures and community mobilization. Important thing here is not work, healthcare community should not work in isolation. It's actually, we require community mobilization that includes businesses, industries, and many of the people involved in the wider community population management. So this is a sort of vector-borne diseases list. So don't try and read that, but it gives you a whole thing, and this will be available to you. And the slides will also be available to you via Dr. Jagdar Wavre. So there's mosquitoes, aquatic snails, black flies, fleas, lice, sandflies, the whole range of these diseases. And today we are looking at these vector-borne diseases. So that is what it is. And the information is also available on WHO websites, okay, and many other websites. So looking at it, they account for 17% of all infectious diseases, okay, which is quite high. They actually cause around 700,000 deaths annually, and they can be caused by parasites, bacteria, or virus. So when you think about vector-borne diseases, it's just not viruses, it's a combination of this. Malaria is one which we are not going to talk about today, but that is also transmitted by the enough-line mosquitoes. 219 million cases, 400,000 deaths every year. And majority of deaths occur in children under age of 5. Now, about 3 years ago, when I was doing a workshop in India, and I talked to many doctors up in Madhya Pradesh and various places, and they actually said that the number of cases of malaria is going down in India. But at the same time, the dengue cases in Chikungunya were increasing. So now the possibility here is that they're both mosquito vector diseases. So if we have been able to get rid of the malaria-causing, transmittable, the vector-borne, which is the mosquito out there, what's wrong with dengue? We should have been able to clear that out at the same time. The explanation to that is that the virus, which actually causes the Aedes mosquito, have become more resistant, and they cannot be cured by the chemicals which we use for enough-line. That's the only explanation we can think of. Otherwise, if we can get rid of all the mosquitoes, we should be able to control it. Dengue, again, is most preventable viral infections. Aedes mosquito, there are 2 of them which are associated with the transmission of disease. 3.9 billion people in 129 countries, they're at risk of contracting, and 96 million symptomatic cases. Estimated deaths are 40,000 deaths a year, which is quite a huge number. So having a look at it, the viral diseases transmitted by vectors, the mosquito virus, chikungunya fever, Zika virus, one of the latest ones, new one, Japanese encephalitis, yellow fever, West Nile fever. I think India is already familiar with the first 3, chikungunya, Zika, and Japanese, and of course there's dengue. They're all transmitted by mosquitoes. There's tick-borne encephalitis, which is transmitted by ticks. Okay, so this is just a simple sketch out here, which is, the virus, bird, West Nile fever into humans. Our dengue fever, dengue fever goes to human beings, mosquito, human beings, or even non-human primates, okay? So this is just a very simple way of actually having a look at it. So what we do have worldwide is a global vector control response, which has been actually approved by WHO Assembly, and it's a program from 2017 to 2030. And this is what we should be looking at, every city should be looking at. The government of India at national level is already looking at it. I'm not too sure whether various state health departments are also looking at this or not, but it gives you strategic guidance for all the partners in actually fundamental approach to preventing disease and responding to outbreaks. And it's a very important document. It also helps to achieve alignment of vector control programs, and it is actually supported to give you technical capacity, improve infrastructure, and it's also strengthened monitoring and surveillance system and greater community mobilization. So perhaps in Zimbabwe, you're already doing it, you're strengthening your monitoring, surveillance systems, and community mobilization is very, very important. And final one is to have, how do we implement comprehensive approach to vector control, okay? The key point here I'm trying to make is the way to prevent dengue, chikungunya, and malaria and all those vector-borne is to control the vector itself, the main vehicle for actually transmitting, okay? And this document is very important, so I strongly recommend that we have a look at it, okay? What does it do? It provides evidence-based guidance for controlling vectors, provides technical support. It will support a country to improve reporting systems and capture the true burden of disease, okay, which is what we are looking at. It will provide training on clinical management, diagnosis, and vector control again, in the collaborating centers, and will support the development and evaluation of new tools, technologies, and approaches of vector-borne diseases, and also disease management technologies. So this is all available. This has been actually published in 2017, and I'm quite happy to forward you a copy for you to look at, because to discuss this particular document and detailed strategy will require more or less 1 or 2 days of workshop, which is not the intention of this workshop, but just create awareness. Okay, so this is just an example. Don't try to read it. This is a WHO fact sheet on chikungunya, and this is sort of the summary of it, what it is. Same is available for dengue and most other diseases. And once again, more information of this will be, I'm going to just link it to you. So the Resources Support Center, these are the links for dengue and chikungunya. And of course, there are many other vector-borne disease fact sheets are there. So if you actually look at, click on these links, you will get all the information you need to know and study at home, okay? So how do we build resilient cities to epidemics and pandemics? It's no different to anything else which we mentioned before. It's disaster medicine planning, it's preparedness, response, and recovery, and which Dr. Sanjay Vavre's team has been doing very well for COVID-19 in Pune, okay? See, the problem we have is still that disaster medicine is not actually well understood in, or implemented in low and middle income countries. I'm not going to read through this. I have done this before in the previous one, mitigation planning. So it's public health preparedness, understanding immediate and long-term effects on individuals and community, health economy, health sectors, where is the funding going to come from if you're going to actually, manage and treat if there is an epidemic of this kind, minimize the effects of infection control and minimize the effect of this disease, infection control, resource management, training and education of healthcare staff is very, very important, and then preparing a checklist for epidemics and pandemics. So this I have done before anyway. Important thing again from zone 3 and the Pune Prandav is capacity planning. If we have an epidemic in the city, have we got enough hospitals, beds, nursing homes? Have we got platelet resources? Have we got enough diagnostic facilities? Because both the diseases can be actually confirmed by serological testing, transport, drugs, equipment. We don't require gases here or PPEs in this case, essential service continuity planning. So these are sort of public education, media management. A lot of times you'll find the media management, the way they present it, people get scared. So again, key steps to epidemics and pandemic resilience. Again, I'm not going to go through all this. Scaling of a country in regional readiness and response operations. Okay, early detection and prevalence monitoring, which Dr. Vavre is doing. Identifying and where necessary, you may isolate the patients or take care of patients much early. This limit human-to-human transmission of the virus, which is here, take the mosquito out, it will stop it. Reduce virus vectors spread from animals, so that is for zoonosis area, not for this one. And isolation quarantine facilities, again, this is for highly infectious area, but it's generally the principles for epidemics and pandemics resilience are already here. Okay, so what are the key challenges to having resilient cities? One of the problems we have here is uncontrolled urbanization. And Pune has had a lot of development and everything. And where a lot of building works occur and a lot of development occur, urbanization occur, you'll find on the building sites, there will be holes and water pockets around, particularly during monsoons. So they are actually the source of mosquitoes. Population growth, again, population living in deprived areas where the water pooling and mosquitoes are there. So these are some of the things we need to look at what is necessary out there into becoming resilient cities. In other areas, in other countries, there are political risk, instabilities and mismanagement out there in Bangladesh and some of the other countries. They have certain, in Latin America, they have these problems. Okay, so what I'm going to say is that, again, we should not, I'm not going to go through this detail, But what we can do as Zone 3, start working on joining, becoming part of the UNDRR, making cities more resilient to epidemics as a program. And now get their documentation, look at where the best practices are. Can we implement it in as a pilot project in Pune Zone 3? And that is all I'm going to say. Thank you very much.
Thank you, Dr. Peter Patel, sir. As you says that community medicine is that much also very important as like a disaster medicine. So your slides was very informative, and with your permission, we can make these slides available on our group, in the Zone 3 group and Disaster Medicine Forum group also. We'll make you these slides available on it, and also we'll make the email of Dr. Vavre sir will be available on our group, so that we should have a good coordination. Peter sir, that was the main motto of our group, PMC Zone 3. As you rightly says that there should be a pilot project or model-like project in this PMC Zone 3 area with the help of Deepak Pakale sir. We will have a mapping of that area. We will give you the data properly, and this will help us to have a good model which can be replicated in other area of the Pune also, that Zone 3 area, this model, which was very helpful to control the COVID also, and that this will be again helpful for controlling the diseases like dengue, malaria, chikungunya, other diseases also. So thanks a lot, sir. Is there any question from the audience or questions?
There is one question from Dr. Sujita. Should we advise caripil tablet to all dengue patients, and how much beneficial it is?
Question to Dr. Paras Doshi.
Dr. Paras, you are on mute. Please unmute yourself.
Yes. So caripil is basically Ayurvedic medicine. It is carry papaya extract, which is given. So there is some controversies that it is not as effective. But see, main is fluid management. Basically, IV fluid management is the main treatment of dengue. So these all things, carry papaya extract and these, there are no such evidences that suggest that giving these tablets are beneficial or there is some improvement in this platelet count. But for the sake of patients' psychology, that some carry papaya extract should be given and some, so there are no such side effects of those tablets. So basically, for patients' psychological issues, you can give, but as such, there is no such effective results of these tablets. So main in dengue is fluid treatment and vitals monitoring.
Correct, Dr. Doshi, as you said, there are no antivirals for either of them. There are no convincing evidence-based antivirals for this. Only supportive treatment is essential, and monitoring the patient and keeping that patient stable. Even some of the mistakes some people make is because there is arthritic pain and swelling much earlier on, they give them corticosteroids, which is also wrong because it suppresses the immune response. So again, you got to be very careful as to what you prescribe and how you treat them. And Dr. Doshi and doctors like him will be able to support the team out there as to what should be done. But most important message I would like to give, with due respect to everybody, is please do not go on WhatsApp and ask for an answer and implement it. Make sure that you get it from an effective, probably an expert who knows the subject, okay, and from right, areas like your Government of India, public health sites or CDC or somewhere else. I have seen many answers given for COVID-19 were completely wrong. And people are saying, oh yeah, that's a good idea. No, please do not do it. Talk to an expert. You have them in zone 3.
Thank you, Dr. Peter sir. So we have here Dr. Deepak Pakhale sir also, who is the basic Dr. Deepak Pakhale sir. He has taken initiative to have these interactions with government medical officers, assistant medical officer of health for the private doctors in zone 3 area. So I will request Pakhale sir to say a few words regarding our this activity in zone 3 area. सर आवाज येत नाही.
अनम्यूट नाही केलं सर अनम्यूट
केला.
अनम्यूट करा सर. अनम्यूट नाहीये तुमचं.
येतोय आवाज आता?
हा येतोय.
हा, तर मी पहिलं सर्व आपल्या डॉक्टर्स सहकाऱ्यांचं सगळ्यांचं पहिलं अभिनंदन आणि आभार पण मानतो की ज्यांनी सगळे आपल्या कोविडच्या या मागच्या 1-1.5 वर्षाच्या काळामध्ये खूप चांगली आपल्याला मदत केली आहे आणि आपल्याला त्यांनी खूप सहकार्य पण केलेलं आहे. आज या वेबिनारच्या निमित्तानं फक्त एवढंच सांगणं आहे की जसं आपल्या डॉक्टर वावरे सरांनी सांगितलं की डेंग्यू, चिकनगुन्या आणि मलेरिया जसं आपल्याला नोटिफाय करणं आवश्यक आहे, त्याचप्रमाणे इतरचे पण जे बाकीच्या ज्या गोष्टी ज्या वेळेस आपण मागच्या वेळेस जे वेबिनार घेतलेले आहे, जे आपण वॅक्सिनेशन असू द्या किंवा ENC असू द्या, तर प्रत्येक डॉक्टरांच्या हॉस्पिटलला किंवा OPD मध्ये ज्या ENC रजिस्टर्ड होतात, जे लहान मुलांचं लसीकरण वगैरे होतं, ह्या सुद्धा गोष्टी तुम्ही आम्हाला ह्या रिपोर्ट करत जा. आमच्या त्या एरियातल्या ज्या दवाखान्यातल्या सिस्टर आहेत त्या आता फील्डवर असतात, त्या आपल्याकडे येतील, याची सर्व आपल्याला माहिती घेतील. त्यांना ती माहिती तुम्ही देणं अपेक्षित आहे. कारण हे ज्यावेळेस कलेक्टिव्हली जसं स्टेटला ज्यावेळेस रेकॉर्ड किंवा रिपोर्ट जातो त्यावेळेस त्याचं रिपोर्टिंग फार कमी झालं असं दिसतं. ऍक्च्युली हे प्रायव्हेट सेक्टरमध्ये आपले सर्व पेशंट्स हे जास्त प्रमाणामध्ये जात असल्यामुळे त्याची रिपोर्टिंग आम्हाला कमी होत. त्या उद्देशाने सर्व डॉक्टरांनी आपल्या ANC बाकीचं जे लहान मुलांचं लसीकरणाचं रिपोर्टिंग जे तुम्ही करत आहात ते पूर्णपणे अगदी 100% करावं अशीच मी सर्वांना विनंती करतो आणि यापुढे पण सर्व डॉक्टरांचं असं सहकार्य लाभो. थँक्यू. धन्यवाद.
धन्यवाद पखाले सर. आपल्या प्रयत्नांमुळेच आपण प्रायव्हेट डॉक्टर्सला वेगवेगळ्या विषयावर वेबिनारद्वारे मार्गदर्शन करू शकलो. आपण सुरुवातीला बळीवन मॅडमचं डेथ आणि बर्थ सर्टिफिकेट संदर्भात मार्गदर्शन केलं. त्यानंतर वॅक्सिनेशन संदर्भातही मार्गदर्शन झालं. जाधव मॅडमनी रिपोर्टिंग करणं किती गरजेचं आहे त्याचं देखील मार्गदर्शन केलं. आणि आज सगळ्यात महत्त्वाचं म्हणजे वावरे सरांनी जे महत्त्वाचं सांगितलं, तर खरोखरच डेंग्यू, चिकनगुनिया हे तसेच कोविडपेक्षाही बऱ्याच वेळा पेशंट क्रिटिकल होऊ शकतात. त्यामुळे आपल्याला ह्या आजारांच्याकडेही लक्ष देणं खूप महत्त्वाचं आहे. आणि त्या संदर्भात नक्कीच आपल्या सर्व डॉक्टर्सला त्याचं बेनिफिट होईल. आपलं जे हे कोऑर्डिनेशन आहे प्रायव्हेट डॉक्टर्स आणि गव्हर्नमेंट डॉक्टर्सचं, हे नक्कीच असंच चालू राहील. मला खास धन्यवाद याच्यासाठीच द्यायचे आहेत डॉक्टर वावरे सर आणि पीटर पटेल सरांना. कारण मी सुरुवातीलाच म्हणलं त्याप्रमाणे हा एक योगायोग होता की पीटर पटेल सर आणि वावरे सरांनी फेब्रुवारीमध्ये 2020 मध्ये जी सुरुवात केली होती ती पखाले सरांमुळे, त्यांच्या टीममुळे अजूनही चालू राहिली आहे आणि अशीच पुढे चालू राहून आपण एक PMC झोन 3चं जे मॉडेल आहे ते चांगल्या पद्धतीने नक्की करूच. मला धन्यवाद द्यायचे स्पेसिफिकली डॉक्टर वावरे सर, डॉक्टर दीपक पखाले सर, डॉक्टर पीटर पटेल सर आणि आम्हाला नेहमीच मदत करणारे डॉक्टर पारस जोशी. सुरुवातीपासूनच ते मदत करतात. त्याचबरोबर झोन 3 मध्ये जे डॉक्टर्स आहेत म्हणजे क्लिनिकल प्रॅक्टिस करणारे आहेत, जनरल प्रॅक्टिशनर आहेत, फिजिशियन आहेत, स्मॉल नर्सिंग होमवाले आहेत, मोठ्या नर्सिंग होम, टर्शियरी सेंटरवाले, हे एक चांगला ग्रुप झाला आहे. त्या सगळ्यांना मी धन्यवाद देतो. आज सगळ्यांनी जो वेबिनार बघितला अटेंड केला त्यांनाही धन्यवाद देतो. परंतु ज्यांना काही कारणानुसार हा वेबिनार अटेंड करता आला नाही त्यांना आपण उद्या पूर्ण वेबिनार, मग त्याच्यामध्ये डॉक्टर पीटर पटेल सरांच्या स्लाइड्स पण असतील, वावरे सरांचा गायडन्स असेल, हे सगळं आपण अवेलेबल करू. आणि हा जो प्लॅटफॉर्म आपल्याला कम्युनिकेशनसाठी उपलब्ध करून दिला, तर ते डिजिशिल्डचे जे माझे मित्र आहेत, दीपेन मेहता सर, आता देखील ते माझ्या बरोबर आहेत. ते स्वतः जातीने लक्ष घालतात. त्यांची टीम जी आहे डिजिशिल्डची, संकेत बराले सर आणि स्पीड टीम, पियुष वगैरे सगळे, तर हे खूप चांगल्या पद्धतीने कोऑर्डिनेशन करत असतं. आपण आता आज वेबिनार घेतला, बऱ्याच जणांची खूप इच्छा असते की वेबिनार अटेंड करावा, पण त्यांना अटेंड करता येत नाही. तर डिजिशिल्ड तर्फे ते पूर्ण रेकॉर्ड केलं जातं आणि तो रेकॉर्ड उद्या पूर्णपणे युट्यूबवर आपल्याला अवेलेबल होईल. आम्हाला आठवतंय 2 वर्षापासून, सुरुवातीपासून, म्हणजे वावरे सरांनी, पीटर पटेलने 2020 मध्ये जे वेबिनार्स घेतले होते की ज्याच्यामध्ये आपण कोविड सेंटर कशी टाकायची, इतक्यापासून सुरुवातीला कोविडचं डायग्नोसिस काय असतं, होम आयसोलेशन कसं करावं, याचे जे वेबिनार अजूनही आपल्या डिजिशिल्डवर उपलब्ध आहेत. मी सगळ्या डॉक्टरांना एक नक्कीच विनंती करेल की त्यांनी डिजिशिल्ड ॲप जे आहे ते डाउनलोड करून घ्यावं. मला वाटतं की आपण जरी आता वेबिनार संपला असं म्हणलं तरी आपण व्हॉट्सअप ग्रुपवर अवेलेबल आहोत. ज्या डॉक्टर झोनथ्रीमधल्या डॉक्टरांनी इन्व्हॉल्व्ह व्हायचं त्यांनी आम्हाला कॉन्टॅक्ट करावं आणि त्यांच्या अजून ज्यांच्या क्वेरीज असतील त्या देखील आपण सॉल्व्ह करू. मला अजून एक विथ परमिशन बाय डॉक्टर पीटर पटेल, की डॉक्टर पीटर पटेल सर हे डिझास्टर मेडिसिन फोरम ग्रुपवर असतात, तिथं ते डेली अपडेट करत असतात. बट आय रिक्वेस्ट डॉक्टर पीटर पटेल सर टू जॉइन ऑन आवर PMC Zone 3 group also, so that we can have your daily updates on that group. आणि बहुतेक सरांची परमिशन मिळाली तर उद्या परवापासूनच आपण त्यांना जॉईन करून घेऊ. आज हा वेबिनार आपण घेतला, त्या वेबिनारसाठी सगळ्यांची मदत झाली, मी सगळ्यांना धन्यवाद देतो. आणि आपण उद्या हा जो वेबिनार आहे तो पूर्णपणे युट्यूबवर अवेलेबल असेल. आपल्या सर्वांचा सपोर्ट मिळणं खूप गरजेचं आहे. आपल्या सर्वांना मी धन्यवाद देतो. आणि कुणाला काही इफ एनीवन वांट्स टू हॅव सम वर्ड्स, पीटर पटेल सर. बट ऑफिशियली आपला वेबिनार संपला असं मी जाहीर करतो. दिस वेबिनार इज कन्क्लुडेड.
Thank you very much, Dr. Jagtap, and congratulations on organizing such a good meeting.
Yes, sir. Thank you. Thank you, sir.
Thank you, sir. Jagtap sir, thank you.
Thank you. Thank you, sir.